Good evening, everyone. Thank you very much for giving me this opportunity. I hope I'm audible.
Yes, ma'am.
Yes, ma'am.
Yeah,
Slide will not be visible.
I'm starting to share the screen. Can you see the screen?
Yes, ma'am.
Yes, ma'am.
Yeah.
Yeah, it's visible, ma'am.
Yeah. So I would start off without wasting much time. So how do I treat extensive stage small cell lung cancer with durvalumab, and what is the real world experience? Just to take the example of one case of a 35-year-old gentleman who presented in June 2021. He's a smoker and he presented with the complaints of change in voice that slowly progressed to aphonia, dysphonia. He did not have any comorbidities. And an ENT evaluation showed that he had a vocal cord palsy. He underwent a CT scan of the brain, head and neck, and chest. The CT, which was done in August 2021, showed a small soft tissue lesion with surrounding fibrosis in the left apical segment, and multiple enlarged mediastinal nodes were there. There was a nodal mass in the iotopulmonary window also that was compressing the left pulmonary artery. Based on the CT scan, because it was a predominantly fibrotic lesion, he was started on ATT, but he did not improve. His condition worsened further, and he started developing CNS symptoms with an episode of seizure in September. That is about a month after starting ATT. So an MRI brain was done in October, and that showed a 2-centimeter lesion, which was there in the right temporal lobe with mild surrounding edema and not much mass effect. And there were multiple other subcentimetric lesions also in the bilateral temporal and left frontoparietal occipital lobes. So that point of time, an HRCT chest was reported that showed a space-occupying lesion in the left upper lobe with mediastinal extension. So this lesion had progressed from the last CT chest, which was done before starting the patient on ATT. This lesion had progressed, and now it was completely encasing the left pulmonary artery. Significant mediastinal adenopathy was there, and there was a consolidation in the left upper lobe. So this was the previous scan, and this was the new scan, which was done in October, that shows a significant progression of the lesion. So that's a progression within just 3 months. And this is another image. Then they went ahead with biopsy of the histopathology, the lesion, and the histopathology showed a small cell neuroendocrine carcinoma. PDL1 was 3 to 4% was the TPS. So the diagnosis is an extensive stage small cell lung carcinoma with brain metastasis. So what is the next step? Whether we go for radiotherapy to the brain followed by systemic therapy, or do we start off with chemotherapy, or do we start off with chemotherapy and immunotherapy? Now, if you look at there is a study on treating brain metastasis in extensive stage small cell lung cancer published in Radiotherapy and Oncology in 2020. And the key conclusions of this study were that for asymptomatic patients, chemotherapy alone is the most commonly recommended first-line treatment. If the patient is asymptomatic with limited volume of brain metastasis, a higher preference is there to start off with chemotherapy without any whole brain radiation. Symptomatic patients definitely require whole brain RT followed by chemotherapy. That's what is most commonly recommended. And symptomatic patients who have limited extent of brain metastasis, maybe in some of them, we can avoid whole brain radiation and we can go for stereotactic radiotherapy as an alternative to whole brain RT. Obviously, if the patient has very severe chest symptoms, we would like to start with systemic chemotherapy first. So that there we have to strike a balance, whether it's predominant CNS symptoms, whether it's predominant chest symptoms, or both are there. If both are there, then the situation becomes a little dicey. But in general, in the clinic, what we do is if a patient has presented with predominant CNS symptoms and limited chest symptoms, then we go for whole brain RT first. Whereas if the patient is not having very overt CNS symptoms, then we can probably put them on prophylactic anti-epileptic drugs, anti-edema measures, medical decompression. And if the chest symptoms are predominant, start off with chemotherapy. It's a very chemosensitive disease. 1 or 2 cycles of chemotherapy with or without immunotherapy, depending on feasibility. And then we can consider whole brain RT in between. This is what we generally do in the clinic. So what does NCCN say for extensive stage small cell lung cancer? If the performance status is good, we go and they do not have localized symptomatic sites or brain metastasis, we go for combination systemic therapy, including supportive care. If the PS is poor, PS3 or 4, then we have to individualize the therapy. If there is extensive stage small cell lung cancer with localized symptomatic sites like there's superior vena cava syndrome, there's lobar obstruction, there are bone metastases, then we need to go for systemic therapy and simultaneously probably go ahead with radiation to the symptomatic sites. If there's a high risk of fracture due to osseous structural impairment, then consider orthopedic stabilization and palliative external beam RT. If there's spinal cord compression, we need to give radiation to symptomatic sites before systemic therapy, unless immediate systemic therapy is needed in patients where the chest symptoms are very, very overt. In extensive stage small cell lung cancer with brain metastasis, asymptomatic patients, we can consider administration of systemic therapy before initiating brain RT. In symptomatic patients, we go for brain RT before systemic therapy, unless immediate systemic therapy is indicated. What are the chemotherapy regimens that we have? We know that time-tested regimen is etoposide platinum combination. And there were a few other regimens, including some pemetrexed-based addition of other targeted agents like bevacizumab or palifosfamide to the etoposide platinum backbone. And none of these have shown any improvement in the progression-free survival or overall survival. So etoposide platinum has remained the gold standard over the last few decades, maybe I can say, and median overall survival never exceeded 11 months, 10 to 11 was the maximum reach. So the patient started square to the brain hippocampal sparing radiation. So what are the systemic therapy options that we have now? We know that immune checkpoint inhibitors have percolated into almost all malignancies treatments, and small cell lung cancer is definitely one of them. So we have carboplatin, etoposide, atezolizumab combination, carboplatin, etoposide, and durvalumab combination, cisplatin, etoposide, and durvalumab. These are the three combinations that we use. The dosing of atezolizumab in the maintenance can be slightly different, 3 weekly or 4 weekly, and we use both carboplatin and so consolidative thoracic patients of extensive stage SCC who have really good responses, almost complete response is there to systemic therapy, then in very selected cases, we do use consolidative RT. But in people, some analysis have shown that the benefit of consolidative RT is maybe limited in patients who have significant residual thoracic disease after systemic therapy. So from cycle 3 onwards, chemotherapy, durvalumab was added to chemotherapy. That we face most of the time in practice, that the decision for adding immune checkpoint inhibitor may be because of the cost, and patient may be able to tell the decision by cycle 2 or cycle 3. So that's what happened even in this patient. We added durvalumab from cycle 3, 1500 mg was given with cycle 3, cycle 4, followed by monthly maintenance. What is the rationale in combining immune checkpoint inhibitor therapy in small cell lung cancer? The theoretical rationale is that chemotherapy-induced tumor cell killing may induce tumor antigen release and expose the immune system more to neoantigens. PD-L1 overexpression is seen in small cell lung cancer, and that causes immune cell invasion and T cell inhibition. PD-1, PD-L1 inhibition restores tumor-specific T cell immunity, and reversal of immune suppression leads to deeper, more durable systemic anti-tumor responses. So immunotherapy plays a role in eliciting an anti-cancer response by modulating the patient's immune response of the tumor. And small cell lung cancer is known to have a very high mutational burden, more neoantigens, and so more susceptibility to immunotherapy. The timing of immunotherapy in relation to other therapies, in particular chemotherapy, is critical to allow disease control and the development of an immune response. So we have the trial, Caspian trial, which was the first and the only approved IO regimen in extensive stage small cell lung cancer, where up to 6 cycles of etoposide platinum was allowed in the control arm, and both cisplatin and carboplatin could be allowed. In brief, the trial design took a total of 8 patients with a WHO ECOG performance status of 0 or 1. Life expectancy of 12 weeks or more should have been there, and at least one target lesion by RECIST 1.1. Stratification was done according to whether cisplatin or carboplatin was used. In the induction phase, durvalumab with EP was used, investigator's choice of cisplatin or carboplatin based on patient fitness, followed by durvalumab maintenance once in 4 weeks until progression. In the control arm, the investigator's choice only EP was used. 4 to 6 cycles, up to 6 cycles was allowed. And there was another investigational agent in the third arm, but I'll not discuss much about this. The primary endpoint was overall survival. Key secondary endpoints were PFS, OS at 18 months, health-related quality of life, overall response rate, and PFS at 6 and 12 months. So the important thing to note here is that Caspian allowed for investigator's choice of platinum, either cisplatin or carboplatin. Patients with asymptomatic or treated brain metastasis were also included. The control arm allowed for up to 6 cycles of chemotherapy, and prophylactic cranial irradiation was also allowed as per the investigator's discretion. So if you look at the differences in the study design between Caspian and IMPAR 133, all comers were included in both the trials. Untreated brain metastases were excluded from IMPAR, whereas Caspian included them. PCI was allowed in both of them, and about 10% of the patients in the control arm, about 10% of the patients in the IMPAR received the PCI. PCI in the experimental arm, about 10% were, took it in the experimental arm also, whereas in the experimental arm, PCI was excluded in Caspian. So only the control arm patients could take the prophylactic cranial irradiation. Up to 6 cycles of chemotherapy were allowed in the control arm in Caspian and not in IMPAR. And cisplatin was not allowed in IMPAR, it was allowed in Caspian. Carboplatin was allowed in both the trials. So if you look at the inclusion criteria, it's of Caspian, it's more reflective of real-world clinical practice. It allowed treatment with either cisplatin or carboplatin. It included patients with either asymptomatic or untreated or treated brain metastasis, compared against up to 6 cycles of chemotherapy with optional prophylactic cranial radiation. The salient aspects of Caspian trial design are highlighted in this slide. I will not repeat it. It's what I have just told. So going to the results, if you look at the progression-free survival, PFS was not formally tested for statistical significance in this trial. That's important. 56.8% of the patients in the control arm received 6 cycles of EP. The median PFS does not look much different. But if you look at the PFS at different time points, at 6 months, there was not much difference. But at 1 year, there was a significant difference of 17.9 months in the durvalumab arm versus 5.3 months in the EP alone arm. And at 18 months, it was still 13.9 months, 9%. And at 24 months, it was 11%. So at 12 months, 17.9, that is at 1 year, almost 18% of the patients were still taking the treatment, and they were still progression-free, as against 5% in the control arm. If you look, there is a tailing off of the graph here, where at 24-month time point, 11% of the patients were still alive, against 3% of the progression-free, against around 3% in at the 12-month time point. So majority of patients who are progression-free at 1 year, that's about 18%, they remain progression-free even after 2 years. So around 11%. So there's a 6% attrition, but still majority of the patients were still progression-free at 1 year. And durvalumab EP is the first and only approved IO to demonstrate a statistically significant and sustained improvement in overall survival versus EP alone at 1 year, 2 year, and 3 year time points. So if you look at the 3 year, the 36-month overall survival, 3 times more patients approximately were alive in the durvalumab arm as compared to the EP arm. That's about 17.6% versus 5.8%. The median OS was 12.9 months in the durvalumab arm against 10.5 months in the EP arm, with a hazard ratio of 0.7. So there's a clear separation of curves and it's sustained with a notable flattening of the curve that's observed from 27-month onwards, which further supports a sustained long-term overall survival benefit. At 3 years, the OS benefit consistently favored durvalumab plus EP across all the patient subgroups that are reflective of clinical practice in extensive stage small cell lung cancer, like performance status, smoking status, presence or absence of brain metastasis, AJCC stage at diagnosis, race, region. So in all the patient subgroups, the ratios favored the durvalumab arm. So durvalumab and EP was evaluated in key patient subgroups reflective of clinical practice, cisplatin and carboplatin eligible patients, patients over 65 years, former and active smokers, and patients with brain and CNS metastasis. So we have a mixed basket of patients in our daily clinical practice, and that is very much reflective in the trial population in Caspian study. The confirmed objective response rates were 67.9% in the durvalumab arm against 58% in the EP arm. So this is the 24-month confirmed overall response rate analysis in the Caspian trial. 24-month duration of response analysis in the Caspian trial showed long-term durable responses, where 13.5% of the patients at the 24-month time point, 3 times more patients remained in response. They continued to respond in the durvalumab arm as compared to just 3.9% in the EP arm. The overall survival based on baseline brain metastasis, if you see, durvalumab and EP consistently improved OS as compared to EP, regardless of the presence of baseline brain metastasis. So with brain metastasis and without brain metastasis, it's giving similar hazard ratios. The median overall survival was 11.7 months versus 8.8 months in favor of durvalumab. The OS and PFS benefit with first-line durvalumab and EP are maintained irrespective of the presence of brain metastasis, further supporting its standard of care use. Those without brain metastasis, it was 12.9 months versus 10.5 months. So both the subgroups benefited. So this patient had a follow-up PET scan in January 2022, and by then he had received radiation, chemotherapy about 3 cycles, and immunotherapy he had received 3 cycles, and the follow-up PET scan showed an excellent response at all sites. So if you see the metabolically active lesion, which was seen in the temporal lobe, that's no longer metabolically active. Again, a follow-up scan was done 3 months later. By that time, patient had received 6 cycles of chemotherapy and 10 cycles of immunotherapy. There was a further decrease in size of the photopenic area in the right parieto-occipital region of the brain. And even the chest, the mediastinal disease and the lung disease also, there was a significant response and there was no disease elsewhere. So durvalumab is the only IO with clinical trial data supporting a 4-weekly maintenance dose administration schedule for extensive stage SCLC patients. So when we are giving induction, we give it 3 weekly along with chemotherapy for after that, maintenance is in 4 weeks, 1500 mg. So that is more convenient for the patient also. Imfinzi with EP is more cost effective as compared to EP alone. If you see the quality of life, the quality and the life years gain also, that despite the long-term uncertainty, the 3-year OS data provides additional confidence in the estimated incremental bit of Imfinzi and EP versus EP alone, and demonstrates the additional benefit as compared to atezolizumab. So treatment with durvalumab is calculated to add 1.14 life years and 0.84 quality adjusted life years compared to treatment with EP alone. So that way, if we see the durvalumab arm with respect to quality adjusted life years also, it did better. So to conclude, first-line durvalumab with EP is the new standard of care in the first-line treatment of extensive stage SCLC because it has shown a sustained improvement in overall survival compared with the robust control arm that is reflective of a real-world scenario by allowing up to 6 cycles of EP, by allowing the use of PCI as compared to the results from the atezolizumab study where PCI was not allowed in the control arm. Durvalumab is the only IO that provides flexibility of choosing cisplatin versus carboplatin along with etoposide. Benefit with durvalumab EP was observed across all the subgroups, including the brain metastasis subgroup. More than 17% of the patients on durvalumab arm survived even after 3 years, showing a prolonged survival benefit in a significant subset of patients. And infancy with EP provided a high response rate and demonstrated ongoing responses at 2 years, where 3 times more patients as compared to the EP alone arm, 3 times more patients in the Durvalamb arm still continue to respond at 24 months. Durvalamb offers a convenient once monthly dosing regimen in the maintenance phase, and the safety findings remain consistent with the known safety profile of Durvalamb and EP combination, and there were no new safety signals. Thank you very much.